everyone. My name is Catalina Dumitrascu, and I'm an anesthesiology resident at the Mayo Clinic in Rochester, Minnesota. It is an honor for me to talk about a project that I will be presenting at the upcoming Spring ASRA in Las Vegas, Nevada. Our project's title is Comparison of 3 Perioperative Analgesic Approaches for Patients Undergoing Major Lower Extremity Amputation. Pain control for patients undergoing lower extremity amputations continues to be a challenge. Many different perioperative analgesic techniques have been studied in the past. Unfortunately, results have been mixed and no technique has been proven to be superior. In fact, the incidence of chronic and phantom limb pain after amputation has been found to be between 30% and 80%, highlighting just how difficult of a problem this can be. In our investigation, we performed a retrospective cohort study of adults undergoing major lower extremity amputation under general anesthesia between January 2012 and December 2017. Patients were divided into 3 groups. The first group included patients that did not receive any regional anesthesia. The second group included patients who received peripheral nerve blockade with standard bupivacaine alone. And our last group included patients receiving peripheral nerve blockade using a mixture of standard and liposomal bupivacaine. A total of 641 unique anesthetics for major lower extremity amputation were included. Our primary outcome was total postoperative oral morphine equivalent use at 72 hours. Secondary outcomes included pain scores at 24, 48, and 72 hours postoperatively, and any pain scores greater than 7 out of 10 in the first 72 hours, as well as postoperative opioid-related respiratory depression. Analyses were adjusted for factors that could influence postoperative opioid utilization, such as history of chronic pain, preoperative opioid use, and baseline pain scores. In multivariable analyses, opioid requirements were 1.5 times greater in the no regional group when compared to those receiving peripheral nerve blockade with combined standard and liposomal bupivacaine. Similar, but not statistically significant, opioid requirements were 1.3 times greater in the no regional group when compared to the regional anesthesia group with standard local anesthetic. Importantly, there was no difference in opioid utilization between patients using regional anesthesia with or without liposomal bupivacaine. These results support that peripheral nerve blockade is associated with superior analgesic outcomes when compared with no regional anesthesia. Moreover, there was not a statistically significant difference in analgesic efficacy when comparing peripheral nerve blockade with standard bupivacaine alone versus a mixture of standard and liposomal bupivacaine. Prospective investigations are clearly warranted to further define optimal analgesic strategies in this high-risk population. That concludes my overview of our project. Thank you so much for listening, and I look forward to seeing you at ASRA.